Thank you all for joining, and I will now introduce today's presenter. Dr. Emily Hill is a research instructor and fellow and registered dietitian nutritionist at the University of Colorado Anschutz Medical Campus. Dr. Hill's research interest centers on the need to more precisely define the relationship between dietary intakes and cardiometabolic health within the context of obesity and cancer. Her goal is to design, optimize, evaluate, and implement sustainable behavioral interventions to improve health and enhance longevity along the cancer control continuum. Her projects span the translational research spectrum from the design and integration of nutrition interventions into established clinical programs to the evaluation of clinical and biochemical indicators of health and alterations to the epigenome, proteome, metabolome, and microbiome after controlled trials. Thank you, Dr. Hill, for being here with us this afternoon. I will stop sharing my screen and turn it over to you.
Okay, great. Hopefully everyone can see my screen. And thank you so much for inviting me. And I always think about when I write those intros that I should really shorten it once I have to sit here and listen to it. So I'm very excited to be here, very excited to share a little bit about what I do. And I'll be talking about a lot of things related to nutrition and cancer survivorship and how we can best support people throughout that process. And I recognize I may be a bit different of a presenter than you may be used to. Oftentimes when people think about clinical trials in oncology, they're thinking about testing new drugs or new devices or other new treatment protocols or regimens. And I want to be here to tell you a little bit about why nutrition matters in both cancer prevention as well as in survivorship. And so this is an evidence summary matrix from the World Cancer Research Fund's third expert report on diet, nutrition, and physical activity and its relation to cancer prevention and outcomes in survivorship. And basically this bubble chart here shows you some of these modifiable lifestyle behaviors and their association with risk of developing cancer. And so the y-axis here, you may guess this is half of a chart, shows the, as you go up the y-axis, it shows the strength of the evidence related to whether or not it decreases risk for different cancers. And then you can see based on the color of the bubbles, what types of behaviors or modifiable factors we're looking at. So for example, blue indicates things related to physical activity, where green indicates things related to things like whole grain intake, vegetable and fruit intake. And the larger the bubble, the stronger the strength of the evidence. And you can see for things like physical activity, we see that that is associated with a decreased risk for colorectal cancer. We also see a lot of these green bubbles, right? And so intakes of non-starchy vegetables or fruit, foods containing fiber, they're all associated with reduced risk of several different cancers, as well as weight gain, which independently is also associated with cancer risk. And so it's really important to focus on being able to modify these behaviors and adhere to diet and physical activity recommendations to reduce your risk of cancer. On the flip side, we also know, and this is the other half of that chart, that there are also modifiable behaviors that are associated with an increased risk of cancer and various different cancers. So for example, some of those green bubbles here indicate that intakes of things like refined grains may be associated with increased weight gain, which then again is independently associated with cancer risk. As you get closer to the bottom, you start seeing things like processed meats or sugar-sweetened beverages are influence our risk for things like colorectal cancer or weight gain. And so I hope that this shows to you that, thinking about these behaviors all together is really important when we're thinking about how they might influence risk for cancer developing in the first place. And so the World Cancer Research Fund has kind of summarized the evidence to create cancer prevention recommendations. And they're pretty broad in scope, and they cover the things that I kind of highlighted on those first couple of slides. So the recommendation is to be physically active, to eat an adequate amount of things like whole grains, vegetables, and fruits, and to limit things like alcohol or sugar-sweetened beverages and red and processed meats. Now, the American Institute for Cancer Research is the American counterpart to the WCRF, and they have the exact same recommendations, but they like to highlight them as kind of a blueprint to beat cancer. And there's a little bit more detail here in their infographic, but the recommendations are the same. And so they want you to prioritize consuming a plant-based dietary pattern. And that doesn't mean, vegetarian or vegan, but just trying to increase the amount of those foods that we know contain things like fiber and other beneficial phytochemicals and other beneficial nutrients for our bodies. And limiting things like, again, red and processed meats, alcohol, and sugar-sweetened beverages. And so these are the cancer prevention recommendations, and they are related to prevention of new primary cancers. But what about cancer survivorship? And so the recommendations are that after completion of active therapy, the nutrition recommendations for this group are very similar to those that are the evidence shows support for the original cancer prevention. So again, it's things like following a predominantly plant-based dietary pattern, limiting some of those other foods like red meats, fast foods, and other highly processed foods, as well as things like sugar-sweetened beverages and alcohol. And you might wonder, why are the recommendations roughly the same for cancer prevention and cancer survivorship? And that's because we don't have a whole lot of evidence in the cancer survivorship population to suggest that the recommendations are much different. And so you can see here, the American Cancer Society right now is the only organization that has put out specific recommendations for cancer survivorship. They published these summary findings in 2022 as part of a clinical recommendation. And you can see, again, very broad recommendations here. So things like avoiding obesity and maintaining muscle mass through diet and physical activity. Encouraging, again, getting regular physical activity and following a healthy eating pattern. But again, we see this recommendation to follow the recommendations for cancer prevention, which those put out by the American Cancer Society are very similar to those that we see by the American Institute for Cancer Research. And that's because, again, we don't have a lot of research in the cancer survivorship space. So this is from that same report where they were looking at the summary of the evidence for specific cancer types. And I've highlighted in gold bars here the diet evidence summary. And so you'll see there are a few bullet points related to breast cancer risk among, prognosis after a breast cancer diagnosis, I should say. And you'll see some things like a healthy post-diagnosis dietary pattern is associated with lower overall breast cancer specific mortality. But other than that, we see a lot of mixed evidence. For some things like colorectal cancer, we know that there are certain foods or food groups that may increase risk for colorectal cancer or increased risk for poor outcomes after a diagnosis of colorectal cancer. But then as we start looking down the list at some of these other cancer types, we have a lot less evidence when it comes to relating to diet. And so for that reason, we really tend to fall back on the recommendations for cancer prevention. And so I just like to highlight that this is an ongoing area of research. Here, there's nothing that they were able to summarize for post-diagnosis outcomes in lung cancer or other hematological cancers. And so we want to focus on what are the recommendations and how do we help people to meet them. And until we have more specific guidance for survivors, we're really going to fall back on meeting the evidence for cancer prevention because we know it can influence the development of new primary cancers, but it can also help to improve other measures of health like risk for cardiometabolic disease. And despite knowing this, I kind of advanced the slide a little quickly here. We know that people with a history of cancer display poor adherence to things like dietary recommendations. And so in this radar plot, I'm showing the overall diet quality for 4 of the top diagnosed cancers in the United States, looking at NHANES data from 2005 to 2016. And if you're not familiar with how we might look at diet quality, we often use a metric called the Healthy Eating Index, which measures compliance with the US dietary guidelines. And the Healthy Eating Index basically scores if you're meeting each recommendation set forth by the DGA. And if you're meeting 0 recommendations, your score is 0. And if you're meeting everything perfectly, your score is 100. So it goes from a 0 to 100. And you'll see here at the bottom that the average score by cancer type is right around in the 50s. So it's not so great. And it's very similar to what we're seeing with the rest of the US. What's really interesting about this plot is it allows you to see each component of that score and how we're doing. So for example, if you're looking at the outside of this plot, if you had a perfect circle, that would be a score of 100, and a point in the center would be a score of 0. And so you can see we're doing a little bit better for things like total vegetables or whole fruit. but generally pretty poor in adhering to the sodium recommendation, getting enough things like whole grains, and really looking about getting enough things like seafood and plant proteins and having the right ratio of omega-3 to omega-6 fatty acids. And so it suggests there's a lot of room for improving our diets in this population. However, we also know that people need support in order to make these changes. And I've talked a lot about diet, but there was a recent report that came out just last year suggesting that only 4% of US cancer survivors meet guidelines that have been put forth for body weight, diet, physical activity, and alcohol consumption. And while we know this is important, we also know that brief consultation when you're meeting with either a PCP or an oncologist really doesn't have a lasting impact on lifestyle behaviors. So a lot of the things that drive my research is understanding, how do we help people modify their lifestyle behaviors? And a systematic review came out, it's been a while ago now, suggesting that multiple health behavior change interventions, so interventions affecting multiple health behaviors at the same time, so thinking about diet and physical activity together, do improve lifestyle behaviors in the cancer survivorship population. But a lot of questions remain. So who should be leading these interventions? Should it be multidisciplinary teams, exercise specialists, or dietitians? Should we address all of these behaviors at the same time or sequentially, perhaps focusing on one at a time? And how do we deliver these interventions? How do people want to receive this information? Is it in person? Is it remote? How long do we meet with them and how frequently? And what does follow-up or maintenance look like once we help people to change those behaviors? Because we know that maintaining them is another part of the issue that we often have. And so a lot of the work I did in my pre-doctoral training was in looking at this post-treatment cancer survivorship space to develop interventions that could help people to improve their dietary patterns. And so I did my work at Ohio State, and we had a cancer survivors garden called the Garden of Hope that was maintained by our survivorship program at the James Cancer Hospital. And so we did our work within the context of this garden. And the very first thing, I think of this in kind of 3 steps to developing a program. The very first thing that we really wanted to focus on is how do we know what people need, And so the first thing that we did at that garden-based, it wasn't an intervention yet, but just the garden-based program, was we conducted focus groups. And we asked people about what they thought about their participation in that garden as a community program. And we heard things from survivors like, oh, I feel like when I'm out there, I'm eating more fruits and vegetables because I'm able to harvest them and bring them home. I feel this sense of community and support and improvements in my mental and physical health from being outside. But when the garden's over, I find it's really difficult to maintain those changes long term. And so we decided to design a program where we provided some support to help people within the context of this garden-based intervention. And we decided that we thought it would be useful to include education on nutrition and maintenance because people had identified that that was difficult for them. We continued to think that access to the garden itself in this case was really important, but how do we kind of limit those barriers for people getting the foods and things that we might recommend? What kind of support can we provide? So we wanted to provide support to individuals. We did this through one-on-one counseling with a dietitian trained in motivational interviewing. And then we also provided tools. So we gave them things like pedometers, and we had a website for them to be able to follow along. We had kind of like tips of the week and a little blog post each week for them to be able to continue to monitor how they were doing over the course of our studies. And then, of course, the next thing we want to do is test and evaluate if our program is working. And I mentioned that the World Cancer Research Fund and American Institute for Cancer Research had put forth those recommendations for cancer prevention that we also ask survivors to follow. Somewhat recently, again in 2019, the National Cancer Institute, in collaboration with the WCRF and AICR, operationalized that score so that we're able to actually measure if people are meeting those guidelines. And so you'll see here kind of on this top little image of a shoe, that's how we look at the score for physical activity. And each component ranges from 0 to 1, where 1 is you're meeting the recommendation, 0 is you're not, and 0.5 is you're kind of in the middle there. For some of these others, weight, for example, is operationalized into 2 parts. Still, the full score ranges 0 to 1, but we're looking at BMI and waist circumference. And then for things like whole grains and fruits and vegetables, they also use a couple of different things to make that score. And so one of the things I did as I was finishing up my PhD before transitioning to my job here is I wanted to see if our program was having an impact on this score after participating in that garden-based intervention. And so this is something that I published soon after graduating, looking at pre to post intervention changes and adherence to each of those recommendations. And so you'll see each line here with 2 bars represents one recommendation. So this is the healthy weight recommendation, which, as I mentioned, is operationalized by looking at body mass index and waist circumference. The top bar for each of these is enrollment or baseline, and then post-intervention is here. And this is the percentage of our participants that were either meeting the guideline, partially meeting the guideline, or not meeting the guideline pre and post-intervention. And so you can see as you move from top to bottom for these bars, they tend to get a little bit darker, suggesting that a greater proportion of our individuals in these programs were meeting the guidelines after our intervention. And so I was really pleased with this, and I think we got really excited, but something that I started to really think about as I was transitioning to my job here is how do we take these interventions that demonstrate some success and implement them into clinical and community settings? So at Ohio State, we had access to this cancer survivors garden, but after the study was over, it didn't actually become a clinical program. So the garden still exists and there's still being research done. But that program we had spent all that time developing hasn't been rolled out as something that's just part of standard of care. And this is really common. So translation of these types of interventions to clinical practice doesn't often happen, and access to them is therefore limited. And there's a lot of potential reasons for this. One, especially in primary care, there may just be a lack of knowledge in terms of what are the survivorship recommendations, how do we connect people with these resources. Another thing that's been identified is poor interdisciplinary communication. So not talking with dietitians or exercise physiologists or physical therapists who might be really instrumental in getting these interventions to the people who need them. Certainly, again, and this is from primary care, time restrictions, and this applies across the board for any provider, right? We know that in a cancer survivorship population, there are a lot of things to manage. We want to make sure they're coming in for their screenings and their follow-ups, and they're maintaining other aspects of their health. So connecting them with these multiple health behavior change interventions, or even providing advice on diet and physical activity is something that doesn't often kind of make the chopping block. And again, this idea of access. So how do we know what programs exist and how do we get them to the people that need them? And so one of the things that I've really focused on since coming here is, how do we integrate our interventions within existing clinical programs so that we can really facilitate their implementation in a way that they'll be around long-term and hopefully be a part of standard of care. So many of you, maybe not all of you, but many of you on this call may be familiar with the Be Fit, Be Well Cancer Exercise program that is here at the university. So this program lives over in the Wellness Center, and it is supported by the Cancer Center, and it's been around for over 10 years now. And this program has been established to support those actively undergoing treatment, as well as those within 6 months of completing treatment. And what this program looks like is it's 12 weeks long, and people come in and meet with an exercise specialist who works specifically with cancer patients and cancer survivors to work through a personalized exercise prescription and a program that is designed to them to help them improve things like their physical function and reduce things like fatigue. And so they meet with a trainer once per week in a supervised session. And then they also get independent sessions they can complete on their own remotely through an app called True Coach. And the Be Fit, Be Well staff basically programs these profiles for each survivor so that they're getting a personalized workout to complete on their own, either at home or in a gym of their choosing. And so it's this combination of weekly in-person support, as well as some kind of, it's still support, but delivered remotely for these individuals. And so as it stands, it's a 3-month program, and it is something that, again, has been around for quite some time. And there's been some research looking at the effectiveness of the program. And Dr. Ryan Marker, who is the research director for the program, published in 2022 some results suggesting that, participating in this program does things like help people to improve their measures of fatigue, things like physical function related to their 6-minute walk test times or their grip strength. And that is perhaps something you might expect from an exercise-focused intervention. However, I was interested in looking at their clinical data to see what about the people that are coming in with overweight or obesity? Are they losing weight? Are we seeing changes in diet? And perhaps not surprisingly, we're not. So in looking at the clinical data collected over about 10 years, I was looking at among those who have finished treatment and have an elevated BMI, are we seeing a change after participating in this 12-week program in either their body weight or in intakes of recommended food groups like fruits and vegetables? And you can see that though maybe for fruit, we saw a slight trend up, those error bars are pretty high. And so we're not seeing much of a change. And, for me, this wasn't particularly surprising because this is, again, an exercise-focused program. And based on that data and anecdotal evidence from participants in the BeFit program, there's a lot of interest in integrating nutrition and providing some support to complement the BeFit program. And so in thinking of that 3-step process that I kind of highlighted there, I first wanted to think about, okay, well, what is the need? And for me, and I think for the BeFit program, they thought, well, we could really use some nutrition-focused programming to integrate. And so I kind of conceptualized this idea of Be Fed, Be Well, which at the time I thought was a very clever name. But then once you start saying like Be Fed versus Be Fit, people tend to interchange them. And maybe it wasn't as clever as I thought it was. But what I did is I wrote a grant to the CPC program at our cancer center in order to develop this Be Fed, Be Well program from the ground up. And so the aims of this pilot were to really engage co-designers through a human-centered design process in order to adapt an established weight management curriculum that had been used at the Wellness Center in order to create the Be Fed, Be Well survivorship nutrition intervention. Again, focused on this group that we know is at increased risk after completing therapy that has overweight or obesity, because we know that excess body weight increases risk for not only a second cancer or a cancer recurrence, but also other cardiometabolic diseases. So really focusing on this high-risk population first. And then working with different individuals, and I'll go through how we did that to accomplish aim 1. And then I really wanted to know, could we deliver this within the BeFit program? So the clinical infrastructure exists. There's support staff. There's already this kind of weekly commitment that they're asking of people. And would people be willing to do a little bit more? Would they want to complete these programs together? And of course, as a scientist, I'm also interested in if the program works. And so we really wanted to start to explore the effects of this integrated intervention on adherence to guidelines, as I had mentioned before, as well as some of those other measures of health like body composition and cardiometabolic health indicators. And so going for that next step in the process, the design of a program, we conducted, and when I say we, I mean I, conducted one-on-one interviews for human-centered design testing with 3 primary groups. So I wanted to talk to providers in the oncology space, and this included our survivorship care plan coordinator, the lead outpatient dietitian, other people working in cancer rehabilitation or cancer treatment, or who have had familiarity with cancer guideline development. I also talked with lifestyle program delivery staff. So these would be the BeFit delivery staff personnel, as well as individuals at the Wellness Center who were really engaged in delivering nutrition or weight management programs, but perhaps not tailored to cancer survivorship. And then I wanted to talk to the people who might actually end up participating in this sort of a program. So I interviewed individuals with a history of cancer and overweight or obesity who had participated in the BeFit program. And so they were kind of familiar with what that program offered, what the structure was like, and they would be familiar with perhaps remaining gaps, not only from transitioning to active treatment, to survivorship and surveillance, but specific to the BeFit program and where we could add some things to provide additional support. And so what we talked about in these interviews, again, were to first start to think about what were the gaps that needed filled. Where did people feel like they could use more support? Where did they feel like they needed additional knowledge when it came to nutrition? And so this really helped us to think about, what might the program really look and feel like. We also talked about the overall message. And so, as I mentioned, as a dietitian, I'm interested in weight management, but this can be a really touchy subject. And so, to asking people what they thought about weight management in survivorship maybe didn't resonate as much with them as talking about overall health and quality of life. I think we spent a lot of time talking about what kind of content would you guys like to see in this program. And it's not only the oncology experts and the dietitians and the BeFit staff who've been fielding questions for 10 years, but the survivors themselves who are at this place where they're just seeking out information and they want to make sure that they're getting it from a reputable place. And so this is where we spent a lot of time talking about, okay, maybe we need some nutrition 101. And, maybe what we really wanted to hear about was, what are the recommendations in survivorship and what other types of things are influencing my life post-active cancer that are maybe related to nutrition, but not specific to nutrition. So a lot of things came up around, emotional and mental well-being and around what kind of behavioral strategies would be helpful for me. Like, I don't know anything about budgeting or grocery shopping, and it's so expensive to eat healthy, and really trying to address what the curriculum or the education might actually look like for this program. And so we spent a lot of time going through different things related to nutrition and survivorship, perhaps more relevant than ever, a lot of questions about nutrition misinformation and how to evaluate sources on the internet or on social media more specifically, for their content and whether or not it's accurate. And then another thing that comes up a lot is, how do we get these programs to people? So we know, or I knew, that I wanted to work within the confines of the existing BeFit program, where people are expected to come into the wellness center for the fitness center access once a week for 12 weeks. And so without wanting to overburden people, we were asking, would you want to come in person for, a separate BeFed session? Would you like those to be delivered remotely? Are you interested in some sort of, hybrid delivery mechanism where some things are on Zoom, some things are in person? How frequently would you like to meet? Knowing that you're coming in once a week for the BeFit program, perhaps, twice a week for BeFed on top of that would be too much, but maybe once a month wouldn't be enough. And so I collected a lot of information from people in these interviews to really get a feel for what they might like to see. And not only the content and how frequently it was delivered and by what mechanism, but what actual intervention components, as I call them, would be useful. And so we did rapid qualitative analysis to highlight major answers to each of those kind of buckets and summarize what was told to us by those 15 different participants. And with that, we created the single arm study where we would ask people to participate in the BeFit Be Well program, again, with 1 day a week in person and at least 1 day a week doing those app delivered exercises. And also this Be Fed, Be Well program. And based on those interviews, we thought people would be really interested in not only nutrition education curriculum, which we ended up deciding to offer weekly for 12 weeks to coincide with the BeFit program, but they also voiced an interest in things like getting group-based support. So having an opportunity to share their experiences, to ask other people about, what it is that they've been going through and what tips and tricks they might have. They really liked the idea of getting to practice some of the things we talked about, working with our culinary dietitians to do group-based skills and cooking demo sessions. And one-on-one counseling with the dietitian was also something people found would be really interesting and helpful for them. And so what we kind of packaged together in this BeFed program was this weekly Zoom-based education. It was all on Zoom and it was delivered in a group setting so people could log on once a week. And then we also did support kind of, woven throughout each of those meetings. So we had time for discussion and questions and sharing. And then once a month, we had individuals come in person to the wellness center in the evening at the same time as their weekly class. And they got to meet with our culinary dietitians on the community nutrition side of things to do taste tests and get in the kitchen and actually prepare a recipe together. And then also once a month, they had individualized counseling with the dietitian that was leading the program. And so again, that takes place for 12 weeks. We were able to enroll 11 individuals into this pilot study. And then afterwards, we did another series of one-on-one interviews to collect feedback on how it went. And so I talked with every individual involved in delivering the program. So this was Be Fit staff, as well as anyone from the community nutrition team or the Be Fed team, or we also had the Cancer Center dietitian join a couple of sessions that were specific to survivorship. So I talked to her as well. And then all of the intervention participants were invited to participate in an interview, but we just had one that we couldn't get scheduled. And we had them come in at 0 months or weeks, at 6 weeks, 12 weeks, and 24 weeks to assess different things. So I looked at diet, I looked at physical activity, we looked at body composition, and we collected different samples from them. So looking at blood, urine, and stool to really see, one, would they actually give us those samples when we move to a larger trial? But two, it allows me to help or allows me to start looking to see if this program has an impact. And so as part of the test and evaluate phase of the study, I wanted to know who we were reaching. And so one of the important things that I have yet to mention is when you're thinking about implementation of programs within existing programs or in thinking about how you might disseminate them more broadly, it's important to think about this within a framework that allows you to really assess not only the outcome related to the intervention, but who's getting it. Are you reaching the people you want to reach? Are they engaged? Are they staying involved? And is this something that could be maintained long term? And so one of the metrics we were really interested in is recruitment. And we were able to screen 78 individuals. And you'll see the majority of the reasons that people were unable to participate is they just didn't have a history of cancer or have an elevated BMI. And so those are things that perhaps suggest that we should try to target our recruitment efforts a little more specifically. But from that, most of the people that consented were interested in participating and passed our additional screening criteria, and then were enrolled in on study. And while we were focused on just any individual with a history of cancer, for this study, it was within the last 5 years, any cancer type, male or female, we did end up recruiting 100% middle-aged white women, primarily. We did have a variety of cancer types, but perhaps not surprising to you, those of you who are working in this space, we had a lot of individuals with a history of breast cancer that ended up enrolling in the study. Though we did have a little bit more variability in terms of SES characteristics. And so, again, speaking to our recruitment efforts and how we better target the individuals we hope to reach with our programs, we really want to think about getting a more diverse sample and reaching people in better ways in order to increase the diversity of our groups that we're able to reach. Of course, I mentioned not only is it important if people are able to hear about and join the study or program eventually if it becomes such, but are they going to come? And so we looked at adherence first and foremost. And at those group-based sessions, so I looked each week for the 12 weeks for the Be Fed program, and our average group attendance was 88%. And so most people really were coming to class every week. We had a couple of individuals who kind of fell off at the end there. We had one individual who had to withdraw for family reasons. But overall, the attendance was really good. And because all of our one-on-one counseling sessions were scheduled individually, we ended up having 100% attendance for all of the one-on-one sessions there. And I kind of alluded to this, but we did have a couple of individuals who ended up not coming back for follow-up. Again, we just had one person who dropped from the study before the 12-week time point because of family issues. And then we had a couple of others who, after that 3-month no contact period, were just not interested in coming back for assessments. So overall, pretty good retention in the study, given that it was our first go of things. Of course, for those of you who are interested in like, well, this is all great to know that you can do it, but does it work? I was very interested to see that we did see improvements in self-reported dietary intake, again, looking at healthy eating index scores. that range from 0 to 100. We saw a significant improvement in healthy eating index scores when we gave them food frequency questionnaires, which assessed their usual dietary pattern over the last 30 days. We saw some trends and improvements in physical activity, though that we didn't have perhaps quite the sample size to be able to pick up on those slight differences. And those were measured by pedometers called active PALs. And then we looked at anthropometrics. We did see improvements in waist and hip circumference and trends towards improvements in body weight and BMI among all of those who enrolled and came back. And then some, again, trends toward improvements in cardiometabolic health. And so this is really promising to me, again, with the 10 of the 11 people that came back. I also wanted to know, when looking at the individual level, did we see any changes? And every single person reported an improvement in their healthy eating index score. And you can see perhaps why we didn't see a significant change in body weight, because while most people did lose weight over the intervention, a couple of people barely changed, and a couple of people actually ended up gaining weight over the program. And so it's really thinking about how might we tailor this in the future to individuals, and perhaps looking at change in body composition, which we do have DEXA data for, but haven't analyzed yet, might be a better outcome. Though, again, thinking about the time frame and what is a realistic expectation for people to change in 12 weeks. Now, all of that is wonderful if we can reach people, if they stay, and if we see an improvement, but it's not going to be any benefit to anyone if people don't like it, or other people wouldn't enroll. And so we conducted another series of interviews where we talked with Be Fed, Be Well participants, all 11, 5 of the Be Fed, Be Well providers, and I have actually since talked to all of the Be Fit, Be Well providers as well to get feedback. And while those transcripts from those one-on-one interviews have been transcribed, they've not been analyzed yet. We did get a lot of feedback on a couple of bigger picture things that we've already started to think about moving forward. And one of those is that people wanted more support over a longer period of time. They felt like 3 months just really wasn't enough. And man, it would have really been nice to have some more contact in that 3-month period where the intervention was over and you didn't talk to us for another 3 months before we came back. Interestingly, in this study, individuals that were in our Be Fed study, upon graduating from the Be Fit program, were offered to pay for participation in the Be Fit alumni program, which they offer. And about half of the people in my study decided that they wanted to do that. And so it got us to think, as we're designing the next phase of the study, is, maybe we do want to provide more than just 3 months of support for this population. And so that was something that really stuck with me as I moved on to this next phase. And another thing that really stuck out to me is this was from our written program evaluation, so not from our interviews. But people really felt like, wow, focusing on health and talking about nutrition and activity together has really helped me to lose weight. It makes me feel stronger. I feel like I'm in control of my health. And I haven't felt that way since I had my cancer diagnosis. And so that, to me, I think really spoke to the positive, like, mental impact of this type of a program for this population. And so then, as we're thinking through, what do we do next, right? So I think a lot about, okay, I could give everybody the whole kitchen sink and think, okay, this is great. I know working with the dietitian is important and people like her. And going into these group-based classes, whether they be on Zoom education or in-person cooking demonstrations, people really tend to like this kind of treatment package approach, if you will. But oftentimes, again, these multiple health behavior change programs aren't getting implemented. And part of the reason for that is we need to think about how we balance the effectiveness of these programs with the things that matter when it comes to getting them into clinical practice. So how do we think about things like affordability? Is it scalable? Is it efficient? Are we making the most of our resources? And so oftentimes in this behavioral intervention space, we do use this, what I just referred to as a treatment package approach, where we take all of these different components of this multiple health behavior change intervention and we package them together, and we have, education, and in this case for BFED, we have group support, one-on-one counseling with a dietitian, hands-on skills sessions. We put them together and then we test them. And so I didn't want to do this because if you go to the randomized controlled trial and you look at all of these things together and compare to a control group and you don't see a difference, now what? You don't know which components might have actually been really useful. So perhaps the group support was useful, but coming in for those hands-on skill sessions took away from that. And just because a component has a positive effect, is it cost effective? If it's really expensive and the institution won't support it, or we can't integrate it into practice, then it's not something that we could include even if it's really helpful. Importantly, it's also good to know if some components just don't work for this population. And it might be helpful to know if there's some sort of interaction between them. So, maybe in the context of one group, having that counseling is really helpful, but coupling it with the weekly group support really allows for some synergy to happen there. And so there's this framework that has been born out of engineering called the multi-phase optimization strategy that allows us to identify interventions that give us those great outcomes given some key constraints that I just mentioned. And so the idea here is that you don't just test this intervention one time and say, okay, I can do it. I'm going to put it in my black box. I'm going to test it against a control group. But instead, you continually optimize it throughout this process. And so in thinking about this, they have kind of contextualized this into 3 distinct phases. We've got our preparation phase, where you really lay the groundwork for the study. You start to think about, okay, what types of components would you include in your intervention? Maybe you pilot test them to make sure that you can actually deliver them. And then you start into this optimization phase. So rather than just going straight from developing an intervention to evaluating it, you take some time optimizing it. And so you might look at different types of trials to identify which components should be delivered, maybe in what order or for what individuals. So there's different types of optimization trial designs that really helps you to make sure that you're building this optimized intervention before you advance to this evaluation phase. And so to contextualize that for what I've been doing in the BFED Be Well study is I am really looking at each of these components separately now in a 2x3 factorial trial to evaluate their main effects. And so I've walked you through step 1 of the preparation phase here, which was the funded pilot that I just went over some of our data for. And so while I didn't show it, I had developed a conceptual model based on social cognitive theory, which was our behavior change model, suggesting things like helping people to improve their self-efficacy through different things like self-monitoring or getting enough support could help them to change behavior. So each of those components I identified was tied to a specific behavior change theory that allowed me to kind of hypothesize why it might work. And then we mapped our intervention components onto those individual theories. So for example, the one-on-one counseling provided some support, whereas the hands-on skills development sessions provided some opportunities for practice to improve self-efficacy. I identified my key stakeholders, which were those 3 groups of individuals that I talked to way at the beginning to say, what would you like to see? How would you like it delivered? What do you think might work and where were the gaps? And from that, I created the core curriculum, selected the components. In this case, the levels of the components are for the pilot study where all of them were just on. So, right, everybody got them. And I piloted them together in a single arm trial. And now I'm in a K99 funded trial, again, funded by the National Cancer Institute, to test each of those components in different combinations in order to see what combination might be the most optimal intervention. And what I'm doing here, I'll show you kind of in a chart form here, is that I'm having 8 different versions of the BFED Be Well program. And so there's a core curriculum that I think is important. It's considered a constant component. And so each individual that's enrolled in the study, I'm targeting 64 total people, so 8 groups of 8, will get access to that core curriculum. Based on the feedback I had gotten from our program evaluations and those one-on-one interviews, we have extended the curriculum from 12 weeks of weekly touch points to 6 months total, or 24 weeks, where we start to taper off that support. So everybody gets the same 12-week weekly education, and then we switch to bi-weekly during month 4, and then once a month during months 5 and 6. So that way everybody gets a little bit longer support and everybody has at least something. So there's no true control group in this type of a trial. And then half of everybody in the study will be randomized to get one-on-one counseling with the dietitian. Half of them will be randomized to get those in-person skills sessions. And half of them, the weekly education during the first 12 weeks, will have a kind of a support group component that's added on to the end. So it's separate from the education itself, where they'll get to have a more structured discussion and an opportunity to share their experiences. And everyone in this study, now I'm just showing what I'm doing with the BFED side of things. From the BFIT side of things, everyone's going to participate in the BFIT Be Well program as I had originally described it. And then everyone is being enrolled in the BFIT alumni program. So that way everybody gets 6 months total of both nutrition and exercise support. And we are going to, again, look to see, are we able to integrate each version of the BFED program into the BFIT infrastructure? And then from the, looking at how do we know if I'm having the effect that I hope to be having, we can start looking at those main effects of each of the components. So for example, this is a really efficient study design. I was not very familiar with factorial trials prior to planning this study. But it allows you to kind of recycle people across different conditions. And so we maintain our sample size of 64, and we have 32 people that are not getting counseling, which are these group, and 32 people that are. And so we can look at the main effect of counseling to see if that is something that would be beneficial to people. We can also look at the main effect of behavioral skills, the main effect of group support, and then we can look at potential interactions between each of those as well. And so the goal here is that in addition to this core curriculum, we'll either add or maybe not add some of these other components to arrive at our finalized BFED Be Well program. And so this study is ongoing. I have enrolled my first cohort of individuals. I am delivering it in a group-based format. So the group-based components are being delivered together. So 2 clusters of 8 in a cohort of 16. So right now, for example, the group that I have is the core curriculum only group, and half of the people in this group or in this cohort are randomized to get counseling one-on-one. And so it allows me to continue to test the study or the program in different ways. And with that, I think I left a little extra time for questions, but I'd like to thank my funders and my collaborators. It would be impossible to do this work without the BFIT staff in particular, as well as all of the people who have helped me to design the program. And with that, I hope I've convinced you that not only nutrition is important in survivorship, but utilizing techniques such as human-centered design, thinking about how we can implement our programs within existing clinical infrastructure, and taking the time to optimize our interventions can really help us to create sustainable nutrition programs that will support individuals throughout survivorship. And with that, I will turn it over for questions.
Thank you, Dr. Hill, that your presentation and the way that you took us from the beginning and your design and the optimization was really great. So thank you so much. We do have time for questions. Feel free to either unmute yourself or place your question in the chat. I will start with one. Oh, we have one already. Excellent. Do you think there can be an impact for Be Fed, Be Well from having more than one feature rather than the particular feature itself? This comment is wondering about if there can be an impact from a couple of programs that are impactful rather than the particular feature of the program.
Okay, I maybe interpreted it a little bit differently. I was thinking like synergy between components, right? So maybe not just getting one of the features, but all versus none. And in both cases, I think the answer is yes. So there could be some synergy, or perhaps there's some, conflict between two of the components that maybe don't work together that end up having a detrimental effect. And we can tease that apart statistically. We're not conducting a fully powered trial right now. So we may not be powered to see some of those interaction effects. But the idea is we could look and say, okay, counseling has a main effect that we see as positive on this outcome of interest, which for me is adherence to the guidelines. We also see that cooking demos have a positive effect, and together the interaction effect is also a positive effect. So we can look at it in that way. Taking it a little bit bigger, which I think, Victoria, you were alluding to, is thinking about this multiple health behavior change intervention. So participating in Be Fed and Be Fit at the same time. And I'll admit this study is not designed to test Be Fed alone. So I am coming at it from this belief that the Be Fit program is great and wonderful and exercise is important. And I want to know if doing this together would be useful. Research suggests that multiple health behavior change programs are more effective at improving overall adherence to the lifestyle behaviors than delivering an intervention specific to diet versus an intervention specific to physical activity. So sort of like when I had told at the beginning of this talk about how Be Fit is really great at improving things like fatigue and physical function, but we don't see changes in diet. I think if you want to see overall adherence to recommendations improve, it's important to provide support for each of those behaviors you're hoping to change. And so I think, though my study is not designed to test Be Fed versus Be Fit, I think literature suggests and previous research has shown that multiple health behavior change programs do end up having some synergy in helping people to change their behaviors. And if I didn't quite get to that question, please do feel free to ask a follow-up.
Great. Thank you, Dr. Hill. As we're waiting for maybe more questions to come in, here is one. I really appreciated the context that you gave to cancer survivors in their lives of post-cancer and the external factors that may impact their ability to meet their nutrition goals. I was wondering if you observed any of those challenges in the program yourself, whether it was from the feedback or the one-on-one counseling sessions.
So most of these people they've been done with their active therapy for at least 3 months, so they're not having any acute side effects. So in thinking of things that you often hear with people going through maybe radiation or chemo, they have very different nutritional needs than this group that I was working with. And so we did hear, maybe not in this study, but in my current pilot or cohort, some people that still had some lingering taste changes. And fatigue is another one that just really lasts for a long time, even after that active treatment phase. And so we do have a whole class in the education sessions devoted to late effects of treatment and some of those other things that maybe aren't going to be, something you would need medical nutrition therapy from a dietitian, inpatient or even outpatient during treatment, but are still worth addressing and thinking about, are there different cooking methods or spices and seasonings that you could use to try to make food taste good again. So that is something that we definitely have gotten questions about. I wouldn't say that we had any individuals that had anything that prevented them from fully participating, but that might have been a product of our inclusion and exclusion criteria. So we are excluding anyone who's undergoing active treatment or anyone who has any significant medical history that impacts things like appetite and digestion of foods. And so our population, while we're not selecting based on a particular cancer type or excluding based on a particular cancer type, inherently is a little bit more homogenous in that we want them to be on the healthier side of survivorship. What is something I'm very, very interested in is once we start to kind of tease out the parts of this program that might be useful is how do we adapt that core curriculum to people who maybe don't have overweight or obesity and shouldn't be talking about weight management, but just general healthy survivorship? Or are there specific recommendations for breast cancer versus a different cancer type, or for men versus women, or older adults versus younger adults? And so really thinking of how we could tailor this program to different populations, even within the general survivorship population.
Excellent, thank you. There is another question in the chat wondering how many years from start to where you are now with Be Fed, Be Well in your design and concept planning. How many years has it been?
I got the Cancer Center pilot in 2022 and developed the program that year, piloted it, 2023, and then piloted it last summer in 2024. So it's just been around for, under 2 years now. And hopefully after this initial NCI funded study, I'll be able to start a bigger randomized controlled trial. But the end goal, of course, is to get this a clinical program at the wellness center, just like Be Fit, Be Well. And so something I didn't talk about that's relevant is, I'm meeting with people in power to think about how are we going to pay for this. So that is something to think about when optimizing a program, when thinking about implementation and sustainability of a program. So we've talked with people at the Cancer Center and people at CU Medicine, which I only somewhat recently learned that are very separate things in terms of how they bill and whether or not the dietitians are billing. And so really thinking about how do we get support, financial support for this program, and can we bill? And are dietitians able to submit reimbursement for medical nutrition therapy? And how do we advocate for our profession? That's a little bit tangential and maybe a little soapboxy, but something important to consider.